Hi, everyone. My name is Amer Zeidan. I'm an associate professor of medicine at Yale University and the director of hematology early therapeutics research. I would like to thank the organizers for inviting me to speak to you today about the therapeutic revolution that we are witnessing in the management of high-risk myelodysplastic syndromes, with a focus on some of the immunotherapy approaches that I have done a lot of research in that area. So this is my email and my Twitter handle, you can see, and feel free to reach out to me for any questions. So those are my disclosures. So I'd like to start with some epidemiologic data about MDS. I think there are few points that are very important to make in the context of MDS. The first one is that MDS is definitely a cancer, and it definitely has overall a poor prognosis when you look at the patient population altogether. So you can see here some data from the registry, from the SEER registry in the US. And what you can immediately see that MDS compared to some of the other more common cancers, the 5-year overall survival probability is actually lower than some of the most common cancers. And it's not that different from acute myeloid leukemia. With MDS, it's around 30%, with AML is around 24%. So it's clearly a disease that has an aggressive nature in many patients, and it should be identified and managed as such. And one of the important developments in the management of myelodysplastic syndromes, especially the high-risk version, was the introduction of hypomethylating agents. And in the landmark AZA-001 study, the median overall survival was improved to 24 months compared to around 15 months for conventional care regimens. And based on this data, azacitidine has become a standard of care in the management of those patients. However, this data has been somewhat challenging to replicate in the real-life setting. So when you treat patients with MDS in the community, the patients have more comorbidities, they are older, they have poor kidney function and poor organ reserve, and as such, some of the outcomes have been difficult to replicate. For example, this is another analysis that we've done in the SEER registry, in which we looked at the survival of patients with MDS who have excess blast. So we don't have the IPSS score in this registry, so patients who have excess blast generally tend to be higher risk, so we use this as a proxy for high risk MDS. And what you can see in the year of 2007 through 2010, so this is an era that followed the approval of hypomethylating agents in the US, which was in 2004 for azacitidine and 2006 for decitabine. The median overall survival improved, but it was only 14 months compared to 11 months. So overall, the improvement has been quite minimal, only 3 months at the level of the population. And this is another way to look at similar data, basically, in the pre and post HMA approval period. And what you can see here is the 2-year overall survival probability. And what you can see in blue is before HMA availability, and in yellow after HMA availability. And you can readily see across the entire age spectrum that the improvement in overall survival across the population have not increased by much. More data to support what we are saying about the need to improve beyond HMA monotherapy. What you can see to the left side is that SEER Medicare large database analysis that we conducted in the US, showing the median overall survival for newly diagnosed MDS patients with higher risk. Again, we used a proxy of excess blast for that. And what you can see is the median overall survival was 11 months with azacitidine and 12 months for decitabine. Again, closer to 1 year. This registry, of course, has only patients who were older than 65. However, in the middle of the slide, you can see from the MDS Clinical Research Consortium, which is a consortium of 6 tertiary centers in the US. So this database includes both younger and older patients, and we looked at 600 patients with high-risk MDS, and most of them have received azacitidine, and many of them have received more than 4 cycles of HMA, but still the median overall survival across all ages was only 17 months, again, significantly lower than the 24 months seen in the AZA-001 study. And further, what you can see to the right side is after HMA failure, the median survival is even worse, 5 to 6 months. So I think all of this data clearly suggests that while HMA monotherapy, which is the standard of care in high-risk MDS, has definitely led to improvement in some outcomes, CR rate of around 10 to 15%. However, it takes 4 to 6 months to reach a complete remission. Many patients never achieve it. Most patients, if they do achieve a response, they will lose the response within 1 to 2 years. And the median survival in real-life analysis is really closer to 15 months than 24 months reported in the clinical trial. So there has been clear recognition that we need new therapies, and there has been a very active clinical research scene, basically. However, the clinical trial development for high-risk MDS, especially after HMA failure, has been quite challenging. And you can see here in this slide some of the reasons for this. I think one of the most important reasons is we realize that high-risk MDS is not only one homogeneous cancer or disease entity, it's actually biologically and molecularly very heterogeneous. And while most patients, more than 90%, will have at least one molecular alteration, what you can readily see that only 5 to 6 of those mutations occur in more than 10% of patients. So there's a long tail of recurrently abnormal mutations, but they occur in a minority of patients. And therefore, trying to target all of these patients with the same therapy is likely to be very challenging. Another important aspect has been the poor understanding of the mechanisms of not only resistance, but also really a mechanism of action of hypomethylating agents. We think that hypomethylation is a major way of these drugs working, but we've never been able to identify reliable predictors of response or lack of response. And most of the MDS patients are older, they are in their 70s, they are living basically with limited social support because their spouses are older or disabled, or many times they are widowed, their children have moved out of town, so they are not able to participate as much in clinical trials. And all of these factors have really impeded participation in clinical trials, and therefore contributed to why we don't have, I think, great additional therapies available. Still, many clinical trials were performed, and you can see here that there has been always an ongoing effort to try to combine agents with hypomethylating agents. You can see here top-line results from a SWAG trial that looked at azacitidine versus azacitidine with lenalidomide versus azacitidine with vorinostat, the histone deacetylase inhibitor. And you can clearly see that there was no difference in survival. But also, we have seen this scenario play out in multiple other situations where a combination with HMA has improved outcomes in a phase 2 trial with high response rate. But once you have taken the combination to a large randomized trial, the outcomes were not different from azacitidine monotherapy. We've seen that with lenalidomide, vorinostat, volasertib, eltrombopag, romiplostim, prasinostat, and most recently with durvalumab. So the management of MDS continues to be risk adaptive. In this talk, I'm focusing on high risk MDS. And what you can see, this is a schema that we actually drafted in 2013. And the reason why I'm showing you the schema from 8 years ago is because not much has really changed since then, aside from two main additions. One was the addition of luspatercept for patients with lower risk MDS who have anemia and ring sideroblasts who are transfusion dependent. But the other major change has been the approval, at least in the US, of an oral version of decitabine that is now one of the options in addition to the injectable azacitidine and decitabine for patients with high risk MDS. However, aside from that, there has been very little change in the overall management approach. But things are starting to change. The dawn of precision medicine or individualized medicine has been coming to MDS, similar to how it has come to acute myeloid leukemia and multiple other cancers. And that's both in the frontline and the refractory relapse setting. So for example, the presence of IDH mutations, and we are going to go over some of this data later in the talk, allows the opportunity to use targeted approaches. However, the problem compared to AML is that IDH and FLT3 mutations are relatively rare compared to acute myeloid leukemia. But still, we have a large number of other agents that are being tested. You can see some of those agents listed on this slide, and we are going to talk over those in the next few slides. So I think the first agent I wanted to discuss of the list is oral decitabine with sidazoriden. So the reason why decitabine could not be used orally is because we have an enzyme called cytidine deaminase. This enzyme is present in the intestine and the gut, and therefore decitabine is metabolized with significant first pass effect, and it's not active as a single agent. So sidazoriden is a novel agent that inhibits the cytidine deaminase, and the combination of those two agents in one pill, basically in one tablet, has been shown to be active in early phase clinical trials with evidence of pharmacokinetic equivalence to IV decitabine. After a dose finding study, this was taken to a phase 3 study, the Ascertain study. And this study have confirmed the presence of pharmacokinetic equivalence between IV and oral decitabine. And the follow-up from this study was recently presented in the American Society of Hematology meeting in 2020, in which the CR rate was confirmed to be 22%, and 32% had marrow CR with a transfusion independence for red blood cells of around 51% and platelets of 50%, and a total or overall response rate of around 61%. So these numbers look similar or are slightly better than IV decitabine. So for all purposes, I think of this drug as very equivalent to IV decitabine and effectively could be used in any situation where decitabine could be used. We still don't have longer follow-up data from this trial in terms of survival, but the CR seems to be durable with a median duration of 14 months. Another oral HMA agent that has been approved is oral azacitidine, CC486. So this has been approved in the US. However, it's only approved in patients with acute myeloid leukemia and not in MDS. So in patients with acute myeloid leukemia who have received intensive chemo and could not continue with curative intent chemo, either after induction or after consolidation, and not after bone marrow transplant. So in those patients, the Quasar study have shown that the oral formulation of azacitidine compared to placebo has improved survival with a median survival of around 22 months compared to 14 months. And based on this data, the drug has been approved. However, in MDS, oral azacitidine has been also tested, and in a randomized phase 3 trial, basically, has been shown to improve transfusion needs and basically lead to transfusion independence in 31% of patients compared to 11% with placebo. However, in the same trial, there was an observation of an increased risk of infection and early death, and that led to no improvement in overall survival, which was not the primary endpoint of the study. So based on this data, the drug is currently not approved in the US for management of MDS, but it's continued to be investigated. And I think the availability of both of those oral hypomethylating agents could open the door for more novel like oral combinations in the future in both acute myeloid leukemia and MDS. How about Venetoclax? So Venetoclax is a drug that has generated a lot of excitement for acute myeloid leukemia. It was combined with azacitidine, and in the Viali-8 trial has shown in this phase 3 trial an improvement in overall survival compared to azacitidine alone, and has been approved where the survival was 15 months compared to 9 months. So there has been a lot of interest in testing it in high-risk MDS. We also have nice data showing preclinical data showing synergy between Venetoclax and azacitidine. So Venetoclax, as many of you know, is an oral small molecule that basically is a pro-apoptotic. It works in the PCL2 pathway basically by inhibiting the sequestration of this agent basically, and leading to increased apoptosis. And the synergy was demonstrated with azacitidine, because one of the common mechanisms of resistance to azacitidine is increase in PCL2 expression. So the addition of venetoclax would overcome that. And you can see here some of the preclinical data using CD34 mononuclear cells, basically from MDS patients, again, showing that the combination of both agents has synergistic activity, both in the frontline and the HMA failure setting. So a study was started where patients received this combination in a dose escalation manner in frontline setting. You can see here the schema, and it's important to note that venetoclax was given for the first 14 days compared to 28 days in AML. So in this study, basically, the escalation was from 100, 200, and 400, and eventually 400 milligram was chosen to be the active dose, again, for 14 days. Early in this study, there was observation of patient deaths during 2 infections. So it's very important that these patients are monitored closely for infections, that we use prophylactic antibiotics. And this is being explored in the phase 3 trial. However, I think with 14 days of venetoclax and careful monitoring, this therapy can be well tolerated in patients with MDS. And early results from this single-arm study that included close to 78 patients have shown high activity with an overall response rate of around 80%. Around half of these, 40%, were complete responses, and the median duration was 13 months. And there was a relatively quick time to onset of response. Median time to CR was around 2.6 months, which is faster than what we typically see with hypomethylating agent monotherapy, which can take 4 months to 6 months for response. And early follow-up data has shown also encouraging survival. However, those results should be taken with caution because it's still single-arm study without a control arm, and it's a relatively smaller sample. How about in the refractory relapse setting, which, as I showed you, has high risks with a poor overall survival? And a similar design study was done. I presented on behalf of our colleagues the results from this study in American Society of Hematology meeting, and an update was provided in the 2020 meeting. And these are the top-line results. Again, venetoclax here was used for 14 days instead of 28 days, which is the standard regimen used in AML. Azacitidine was used for the 7-day standard schedule. And the overall response rate was around 40%, while most of those were marrow CRs, around 7% had complete remission. But I think it's important to note that many of the patients who had marrow CRs had also improvement in their platelet and red blood cell counts with transfusion independence. And the median overall survival was close to 14 months, which is comparing for those with marrow CR and 12 months for the entire cohort, which compares, of course, favorably to historical rates of around 4 to 6 months. But again, single-arm study, relatively smaller sample size, and I think we need better understanding of this regimen to see how the use of venetoclax can be used in high-risk MDS. And of course, a very big part of this is the phase 3 trial, which is ongoing, the Verona study, which is looking at combination of azacitidine with venetoclax compared to azacitidine in the frontline setting. Another drug that has generated basically excitement is pivonidistat. This is a first-in-class inhibitor of the NID8 activating enzyme. And this inhibition of this enzyme basically blocks ubiquitination of select proteins which are upstream of the proteasome, and that leads to disruption of cell cycle progression and survival with selective pre-apoptosis in some cancers. And it has exhibited synergistic activity in preclinical models, basically in combination with hypomethylating agents. So after phase 1 studies were done in AML and MDS, a randomized phase 2 study was initiated in high-risk MDS, but also in patients with high-risk CMML and oligoplastic AML. And you can see the design of the study, in which 120 patients were randomized in 1-to-1 fashion to receive azacitidine with pivonidistat versus azacitidine alone. And the primary endpoint basically was originally event-free survival, but this was subsequently changed to overall survival based on regulatory feedback. So this slide summarizes the top-line results from this study. There was really marginal improvement in event-free survival, 20 months versus 15 months with a p-value of 0.045. But important to remember that this is a subgroup analysis of the patients with the higher risk MDS, which were 67 patients, not the overall study in which the event-free survival, also the overall survival were not significant. But I think what was interesting really is that the overall response rate was quite high, 80% almost, with around 50% having complete response. So those numbers are definitely encouraging. They appear better than the azacitidine monotherapy. Again, the p-values are borderline, but also the durability of the responses seemed good. However, there was no difference in overall survival, but clearly the study was not powered to look at it. So I think many of us are waiting for the results from the phase 3 Panther study, which randomized patients to receive azacitidine or azacitidine with pivonidistat. And this study has completed accrual, and we are waiting for the results to see how pivonidistat can fit in the management of patients with MDS. I think another group of agents has been targeted agents. I mentioned at the beginning that IDH mutations are seen in MDS, although they are not as commonly seen as in acute myeloid leukemia. The rate is around 5 to 10%. Those drugs also have activity in MDS, and as can be seen in the next couple of slides. So this is a small study looking at 12 patients. So this is basically the study that led to approval of ivosidenib in patients with AML. However, this trial also included a small number of patients with MDS. And what you can see here is that 12 patients were included with MDS. 9 of them had HMA failure, and 5 of those 12 achieved complete responses, with 9 of 12 achieving some kind of response. And some of those responses are durable, as you can see in the swimmer's plot. So clearly showing activity of ivosidenib in this setting. And while it's not approved by the FDA, we definitely have used it off-label for patients after HMA failure in whom we could not go to transplant or have clinical trial options. Similar data were generated with inacidnib, which is an IDH2 inhibitor. And in this analysis, again, from the study, the big phase 1 study that led to the approval of inacidnib in AML, they had 17 patients with MDS, and 13 of them have HMA failure. And what you can see, 6 have achieved some response, with some of those being durable. So similar situation, we consider use this drug, again, off-label in patients with high-risk MDS after failure of HMA monotherapy. Now studies are looking also at using inacidnib as monotherapy, as you can see in this study from the MD Anderson group after HMA failure, but also as combination therapy in the frontline setting, similar to what is going in acute myeloid leukemia. So I think these are clearly important targeted agents being studied. I don't have a slide on the FLT3 inhibitors, but FLT3 mutations can happen very rarely in MDS patients, and there are like case reports of using FLT3 inhibitors, again, off-label in those patients. About targeting immune dysregulation myeloid malignancies, which is the focus of the second part of my talk today. So there are multiple immune aberrations and dysregulations that occur in patients with AML and high-risk MDS, leading to basically immunosuppressed environment, microenvironment with T-cell exhaustion and senescence. There is dysfunctional T cells, as well as increased expression of co-inhibitory molecules and tolerogenic dendritic cells, leading to exhaustion, increased expression of regulatory T cells, and dysfunctional and deficient NK cells. And all of that basically leads to weakness of the immune response to the malignancy, which leads to propagation of the malignancy. And all of that have led to efforts to try to energize the immune system so that it can work against MDS and AML, as we can see. And one of the ways in which the development of immunotherapies have focused on is the development of antibodies. The other way is the development of CAR T cell therapy in myeloid malignancies. This will not be the subject of my talk today. I'm going to focus more on the antibodies that are currently in testing. So the antibodies that are used in myeloid malignancies basically are in three main classes. One is direct conjugation to cytotoxic agents, antibody drug conjugates, as you can see in this list. And gemtuzumab ozogamicin is an approved drug for AML that is an antibody drug conjugate against CD33. However, none of those are approved in MDS. Another group of antibodies are the bispecific T-cell engagers. And you can see some of those. Many are under clinical trial testing, but none approved in AML or MDS. And the third group of drugs or third group of immune antibodies, the one I'm going to focus on today, are the immune checkpoint inhibitors. So you can see in the schema that there is a large number of those pathways, and the classical ones, PD-1, PD-L1, CTLA-4, are the ones who have been tested the most, both in solid tumors but also in myeloid malignancies. However, some of the new inhibitory immune pathways such as TIM3, such as LAG3 and TIGIT, all of these also are being tested, as well as CD47 for the macrophages. Before we go into details of some of the immune checkpoint inhibition data, I also wanted to show some data supporting how does the genetic landscape can also interact with the immune landscape of the tumors. So for example, we know that TP53 mutation is highly detrimental from a prognostic point of view in patients with MDS and AML, really. And we also found that it's not only having TP53 mutation, but it's also about the variable allele frequency and whether it's a monoallelic or a double hit. And you can see here clearly that patients who have double hit do much worse than the other patients, while patients who have only monoallelic abnormality, they tend to do relatively better. So patients who have high allelic burden with TP53 or multi-hit, for example, loss of chromosome 17 in addition to TP53 mutation, tend to do the worst. And for TP53 specifically, this drug APR246 has been developed, which is a TP53 refolding agent, and has shown early activity in this study that has since been published in the JCO paper or journal. And the combination of APR246 with azacitidine have led to responses with a CR around 50%. Many of those were durable. However, the randomized ongoing phase 3 trial of APR246 with azacitidine versus azacitidine alone have not met its primary endpoint, which was a significant improvement in complete response rate. This has not been achieved. However, the trial is still ongoing, and we are waiting for data from this trial to see whether this drug has a place in the management of TP53 mutated MDS, which is clearly a high unmet clinical need. TP53 mutations as well has been shown to be associated with significant immune dysregulation and an immunosuppressive environment with increased expression of inhibitory immune molecules such as PD-L1. And I think this is a part of why there has been a lot of appetite to try to target these patients with immune checkpoint inhibition or immune activation mechanisms. Some of the early trials that looked at manipulating the immune system, this is an example of one trial that we conducted using high-dose lenalidomide in patients with refractory high-risk MDS or AML. The approved dose, as many of you know, is in MDS is 5 to 10 milligram, which we generally use in patients with deletion 5q. Here, based on data suggesting that using higher doses, such as 25 to 50 milligram, could be active in patients with AML or MDS. We conducted this analysis. However, the high dose was quite difficult to tolerate. The median overall survival was quite poor, and clearly this was not a therapy that could be very tolerated. But moving from that, I think some of the more selective or specific immune modulator type of agents, such as Epilimumab, started to intrigue us more in terms of potential activity in hematologic malignancy. For example, Epilimumab has been shown in this paper that was published in the New England Journal of Medicine. When it's used post-allogenic bone marrow transplant relapse, that it has activity, and actually 5 out of 13 AML patients achieved complete remission, although most of them had extramedullary disease. But again, kind of confirming that immune checkpoint inhibition can have a role in the management of hematologic malignancy. So we took this basically to higher risk MDS in the HMA failure setting, and we looked at Epilimumab, the anti-CTLA-4. We actually, based on this phase 1 concept, based on data suggesting increased expression in CTLA-4 in patients who receive azacitidine or combinations with azacitidine with vorinostat, suggesting that resistance to azacitidine could be mediated through increased expression of CTLA-4. And based on that, we designed the Epilimumab monotherapy trial with a dose escalation followed by a dose expansion schema. As you can see here, the dose levels. This was given every 3 weeks and in an induction followed by a maintenance phase for those who responded. So 29 patients were included in this study that has since been published in the Clinical Cancer Research Journal from Yale and 5 other centers. We used 2 dose levels. Initially, we saw a lot of immune-related adverse events. However, with the expansion, we did not see additional immune-related adverse events. All of those immune-related adverse events were reversible with drug discontinuation and systemic steroids. However, the responses were minimal. We only saw 1 marrow CR in 1 patient, but we did see prolonged stable disease for more than 46 weeks in 7 patients. 3 of them had stable disease for more than 1 year, which begs the question of this is a biologic modulation from Epilimumab, or is it just that those patients happen to have more indolent biology to their MDS? Of course, this question cannot be answered from a single arm study, but it does remind us of what was observed in solid tumors when immune checkpoint inhibition was used, is that some patients achieve stable disease, prolonged stable disease as a real clinical benefit. And I think that's important to keep in mind when we evaluate these drugs in MDS patients. We observed also some important biomarkers. For example, we observed increased frequency of ICOS, which is a co-stimulatory molecule, and this seems to correlate with benefit from Epilimumab among patients who had, among the patients who had achieved marrow CR or those who achieved prolonged stable disease. We also observed with the Epilimumab increase in T cell receptor diversity, but there was no correlation of that with clinical outcomes. However, we did not observe any relationship between the clinical benefit from Epilimumab with serial changes in absolute lymphocyte count, in T regulatory cell frequency, or in the CD8/T regulatory ratio. So I think this data again supports that there should be extensive look at the biology of what happens with the immune checkpoint inhibition studies to better understand how we can find biomarkers that can identify responders. And while we didn't see a lot of clinical activity in terms of responses in our study, another study from the MD Anderson group in which azacitidine plus minus nivolumab or plus minus Epilimumab were studied both in the frontline and HMA failure setting, they actually observed more activity with Epilimumab. So an overall response rate in HMA failure setting with Epilimumab was 30%, which is higher than what we observed, which was around 3%. However, the median overall survival that they observed around 9 months was somewhat similar to what we observed, which again suggests that there could be important differences between patients in the microenvironment of the bone marrow, and suggests that there could be some selection strategies that should be used when we conduct these immune checkpoint inhibition trials so that we can select patients who are more likely to respond. So this got us to think about what is the reason why we are seeing failure of immune checkpoint inhibition with CTLA-4 inhibition at least, compared to the very good activity that's seen in some solid tumors such as lung cancer and melanoma. And we actually generated some data looking at the myeloid-derived suppressor cells. This is from my colleague Tae-Kon Kim, who has since moved to Vanderbilt, in which we have shown that patients with MDS have increased expression or increased number of myeloid-derived suppressor cells, increasing the immunosuppressive environment as MDS progresses and as they evolve into acute myeloid leukemia. But also, we showed that entinostat, which is a histone deacetylase inhibitor, has a synergistic activity with the PD-L1 blockade in the murine myeloid leukemia models, where the best survival was with entinostat in the PD-1 knockout mice, again suggesting synergistic clinical activity in this setting. And based on this data, we took this data to the clinic, and we designed a study of the anti-PD-1 pembrolizumab in combination with histone deacetylase inhibitor entinostat after HMA failure, with the idea that resistance to PD-1 and PD-L1 seems to be mediated by myeloid-derived suppressor cells, and targeting them with entinostat might restore activity to immune checkpoint inhibition with pembrolizumab. So this trial is currently ongoing, and we hope to report on the results in the near future. So most of the studies that looked at immune checkpoint inhibition have been like single center and small sample size, and clearly we need randomized data. So the first randomized study that has been conducted and published with immune checkpoint inhibitor in high-risk MDS is the Fusion study. We presented this data 2 years ago in ASH meeting. So in this study, it had AML and MDS. In the high-risk MDS arm, which had 84 patients, in this cohort, patients were randomized to 2 arms, azacitidine alone or azacitidine with durvalumab, which is an anti-PD-1 antibody. And patients were treated until disease progression or toxicity, with the primary endpoint being the overall response rate, but we did also look at overall survival and progression-free survival. And you can see here a summary of the results, which showed that there was no improvement in the overall response rate with a p-value of 0.18. We did see numerically higher rates of marrow CR with the combination, which was 35% compared to 19%. But there was no improvement in overall survival or progression-free survival, as you can see in this data. However, I think this data really is indicative of lack of activity of only durvalumab and does not necessarily extend to PD-1 or some of the other novel immune checkpoint inhibitors. And we did extensive correlative immune testing within the context of this study to try to understand the lack of activity. And I think an interesting finding, we found that azacitidine increased PD-L1 expression in the bone marrow immune cells, but not on the tumor blast. So maybe PD-L1 expression on tumor blast basically is not a very important mechanism for resistance to HMA in this setting. And I think this is important theory to look at in subsequent studies. We did, as expected, observe global demethylation basically in the majority of patients with MDS and AML within the context of this study. About another immune checkpoint inhibitor, sabatolimab or MPG453. So this is a novel immune checkpoint inhibitor. And I think an important aspect of this antibody is that it doesn't only act as an immune checkpoint inhibitor. So TIM3 is expressed on macrophages, monocytes, as well as T cells and dendritic cells. So both innate as well as adaptive immune cells. But also it seems to be expressed in leukemia stem cells in addition to those immune cells. However, not expressed on the hematopoietic stem cells. So this antibody, the MPG453, seems to act both as an immune checkpoint inhibitor, but also as directly cytotoxic against the leukemia stem cells. And early data has suggested synergistic activity in combination with hypomethylating agents. Based on that, a clinical study was conducted, and this was presented recently in the American Society of Hematology meeting, showing that the combination seems to be clinically active with high rates of overall response rate, around 64% in newly diagnosed very high risk and high risk MDS based on the revised IPSS criteria. Although the CR rate did not appear much higher, it's around 23% compared to monotherapy, which is around 10 to 15%. But many of those patients had durable responses, as you can see in these swimmers plots. So I think the data does suggest active activity of this agent. And based on this data, randomized phase 2 trial of azacitidine versus azacitidine with sabatolimab has been initiated, called the Stimulus MDS-1. This study has completed accrual and it's currently in follow-up, and we hope to have results in the near future. Another ongoing study is the phase 3 Stimulus MDS-2, which is a phase 3 trial of azacitidine versus azacitidine with sabatolimab. And I think both of those studies are going to be very important to better understand the use of sabatolimab in the context of MDS patients. This agent is also being studied in AML in a azacitidine venetoclax with sabatolimab type of study. And lastly, in the last couple of slides, another, I think, immune checkpoint inhibitor that works on the macrophages, an anti-CD47, the don't eat me signal. So CD47 basically is expressed on many cells as a way to inhibit macrophages from engulfing normal cells. And this pathway is hijacked by several cancer types, including leukemia, where the CD47 expression is increased. And it has been shown that inhibiting this pathway can lead to increased phagocytosis of leukemia cells. And it's one common pathway that leukemia and also MDS cells can use. So based on this data, several anti-CD47 monoclonal antibodies have been developed. One of them is this agent CC90002, which was studied in a refractory relapsed setting as monotherapy in a 28 patient study. Most of them were refractory relapsed AML, but 4 were in high risk MDS. And this was a dose escalation study. But this study clinically was negative. We did not observe responses in this study as a single agent, largely because of the development of human antibodies basically. And I think the use of monotherapy also might have been an issue in this study, because another anti-CD47, magrolimab, this agent basically, when combined with azacitidine, has led to significant reduction in blast. I'm showing you here AML data, but similar data with MDS, where there was significant blast reduction. It seems patients who have TP53 mutations seem to also particularly to do better compared to patients who are receiving azacitidine alone. However, this data, again, is single arm, smaller study, less than 50 patients, and early in follow-up. So I don't think we can make a lot of conclusions based on that. But there's an ongoing phase 3 study looking at the combination of magrolimab with azacitidine versus azacitidine alone, called the ENHANCE trial. And I think the results of the study will be very important to better understand where this agent will fit in. So in conclusion, there's a large number of active clinical agents in clinical trials that are being tested. I think some of the most exciting ones, such as sabatolimab, venetoclax, pivonidistat, the IDH inhibitors, as well as the APR246 and magrolimab. All of these are being tested, but there's a large number of other agents that are being tested as well. But I think regardless, I think it's very important that we enroll patients in clinical trials so that we can continue to move the field forward and not just routinely use HMAs as monotherapies in the vast majority of patients, because we clearly recognize now the limited activity of HMA monotherapy. And I think combination-based strategies is definitely the way to move the field forward. So at the end, I like to acknowledge the organizations that funded my work, especially the Leukemia Lymphoma Society and Conquer Cancer Foundation and the MDS Clinical Consortium, as well as the Aplastic Anemia and MDS International Foundation. This is my email and my Twitter handle, and I'm happy to take any questions. Thank you so much.